You're listening to Through Help and Back. Through Help and Back is a podcast focused on mental health, addiction, treatment, recovery, and all things related to personal improvement and wellness. Don't worry, we're not here to talk about problems without solutions, and we're definitely not here to talk about struggles without success. So come with your problems, leave with our solutions. All right, here we go. Welcome to Through Help and Back. As all of you know, because you're tuned in, Through Help and Back is a podcast focused on issues related to mental health, addiction, recovery, resiliency, bouncing back, everything from a positive frame of mind. Speaking of positivity, speaking of being upbeat, speaking of being excited to be here, we're very happy, mostly because, one, Ian is here and he's in a good mood, and you can't see him, but he shaved all of his facial hair. So that's something to really think about and be positive about, because we're positive he needs to grow it back. But more than that, we are excited because of our guest. We have Mrs. Jenna Overbaugh, who is an LPC, which means she is a licensed professional counselor. She specializes in the treatment of OCD, which I'm really excited to talk about. Anxiety, which I'm also excited to talk about. She has a podcast herself, and she's very active in this space, not only in terms of her research, in terms of her innovative treatment methods, but just her mindset and her energy and her solutions that she brings to this field. So, Jenna, we are very, very, very happy to have you. Thank you so much for coming by.
Thank you for having me. That was such a nice intro.
Oh, I practiced. Last night I stayed up and I said, Jenna is going to bring some great energy, so I need to match that right out of the box. So
I'm ready. I'm so stoked to be here, and everything that you guys do, I totally stand for. And I'm just excited to help you take that to the next level as far as doing the tough things and, understanding these things a little bit better.
Yeah, no, absolutely. And I truly mean that. So when I've been a therapist for a minute, you've been a therapist for a minute, and I've worked with a lot of anxiety. I've worked with less on the OCD side. So I'm very excited to tap into your expertise and your perspectives on that. But tell us a little bit about your background before we get going. Now, where are you in the world? Where are you practicing? And how did you fall into this being a helper, getting into the helping professions? How did this develop for you?
Yeah, so I am in Wisconsin, which a lot of people don't even know where the heck Wisconsin is. I know that's how I felt when I got asked to come and kind of get my dream job. But I love it. I love Wisconsin so much. So yes, I am a practicing therapist here in Wisconsin. I'm also licensed in a couple other places, but way back when I was a young buck, I knew from a very early age that I just had this anxious energy about me. I was a very anxious person. I remember, going to a new school and being afraid to sit with new kids at school, or, oh my gosh, what if the teacher calls on me and I don't know the answer? Everyone's going to look at me and laugh. And in hindsight, so many other things. Like, I don't even think I told you this before, but I loved the band Hanson. Anyone who's listening is going to either know them or not know them. The band Hanson, they were really big when I was young.
Mbop, yeah.
Yeah, they were my favorite band. They were my favorite band of all time, just like my first loves. But I really, really struggled. I felt like I had to do everything in threes because there were 3 band members. And I felt like if I did something 2 times, then one of those 3 band members would die.
Sure.
And that's so obviously in hindsight, that's so crazy. And that sounds so ridiculous. But as a kid, we're so gullible and we just feel the way that we feel and we don't really question it. It's just, we think that that's just the way that the world is. And so I remember tying my shoes in multiples of 3. I remember opening and closing doors 3 times or writing things 3 times, because if I didn't, then it would be my responsibility if something bad ever happened to one of the Hanson brothers. And so more than it did, I'm sure, throughout the years, but I knew that I wanted to be a therapist. I knew I wanted to help people. Because I felt so empowered when I would do something 2 times instead of 3, and I would just really stick it to the man, or I would feel really empowered when fine, I'm just going to raise my hand and whatever happens, happens. And who cares if people are looking at me, whatever. Just felt really good to just say, I'm just going to do what I want to do. And I started to feel bold in that. I started to feel more confident in myself. And I wanted to help other people feel that way too. I wanted other people to not have to hide or to do these things that, anxiety or fear was telling them to do. But I didn't want to be one of those therapists that 15, 20 years ago, the stereotype was, oh, how do you feel about that? Here's a tissue, just like listen to things. How do you feel about that? Talking about childhood or dreams or whatever. I wanted to be in there and like doing stuff with the people. And then in college, this was in 2008, I learned about exposure and response prevention, which is come to find out, the frontline treatment for OCD and anxiety. And it essentially is just exactly what it was that I was doing, right? It's this concept that you have to go outside of your comfort zone. You have to kind of face your fear versus avoid it or try to cope with it. And you reduce the safety behaviors that you used to do to try to cope with that anxiety provoking situation. And I was like, this is me, this is everything. This is my wheelhouse. Like I am meant to do this. And so from that point forward, it was every internship, every research paper, every job that I could possibly find, every volunteer opportunity. It was about OCD or anxiety or about this treatment, exposure and response prevention. I just fell in love with it. Eventually went on to study it more and become more just specialized in that niche. In grad school, I worked at Johns Hopkins with kids and adolescents with OCD and anxiety. I thought I wanted to work with kids. Then eventually I got asked to come, and it was my dream job at the time. I remember telling my mom at one point, like, I really want to work somewhere where they have timed showers. And like, such a nerdy thing to say, right? Like,
it's just very specific.
I know. Like, I guess I must have saw it on TV or something. But they essentially have these facilities where like really, really, really deeply debilitated individuals, they kind of go and they get really intensive treatment. And that was the dream job that I was offered. I was kind of found at a conference, and the clinical director at the time, his name is Dr. Riemann. He's really well known in our field. He found me and he invited me out here. And I was there for almost 10 years. I was there for almost 10 years working with like the most debilitating cases, most complex cases of OCD and anxiety. So literally the best research and best education and training that you can imagine. And then at the turn of COVID, I realized like if I ever wanted to ever do anything on my own, I would have to get comfy with social media. Because everything was modernizing at that point and going technology, right? So like whether I liked it or not, that was the way that the field was going. And so I just like got a microphone and started to riff on some podcasts, and I started to just create some things on Canva for social media. And for the longest time, it was just my grandma following me, but now it kind of exploded, and that's what I do. So that's what I do now. I try to educate people about OCD and anxiety on a much larger level. I still see some people like one-to-one, which is great. But I focus more so on like mass scale education and information. And I also really like to work with other therapists, like train other therapists and being able to understand and treat these disorders too.
So are you still doing the 3, like you're posting 3 videos a day so that Hanson doesn't die, or like what?
So it's weird, right? And we can talk about this, but like OCD, it shape shifts. Like it has like this whack-a-mole kind of esque nature to it. So I'm not as like, for lack of a better word, like I'm not as obsessive about Hanson anymore, but I am super obsessive about my child. I have a 5-year-old. And so, and my dogs, I have 2 dogs that I adopted who we had them before I even had my son. And I will find myself not necessarily having to do things in like twos for my 2 dogs, but I will find myself like, if I give one dog a treat, I have to give the other dog a treat. Right. So like, it's all very sneaky. It's all very, very sneaky. But that's why I think it's so important for people to learn about it, right? Because superficially, you might not think that those 2 things are the same, right? Like, oh, I have to do things in threes because of Hanson, or, oh, I gave this dog a treat, so I have to give the other dog a treat. Like, knowing what I know, I see that as the same entity. I see that as the intolerance of uncertainty, fear, doubt, but someone else might not see that.
Yeah, it just manifests itself in different ways, right?
Totally.
Yeah, it's the same driving force, the same driving compulsion, or the mind bug. I've heard it described in the past as sort of a mind bug that kind of stays with you, right? But it's showing up in different ways. It's interesting. There's so much to unpack there, and it's amazing your journey. First off, thinking about no accidents and coincidences, and you're obsessed with this and dealing with this, and this is what your passion is, and you just happened to end up at a conference with like a leading researcher, and it just
I didn't even want to go to this conference. Like I was like, get me out of school. I'm so done with school. I just want to go and like get a job at a Starbucks and be a barista. Like I was just so over it. Didn't want to go. I ended up getting a scholarship. I almost missed my flight. I forgot about the time difference. So this was it was in a different time zone. So I was late to my presentation. Like there's no way that I should be here right now. But like, I really believe in that stuff. Like I believe in that stuff. Like there really, truly were no accidents.
No, it's real. And I can connect with you on that because when I went to TCU, same deal. I went to a sports psych conference and I met a former Notre Dame quarterback who was presenting, who just happened to be a professor at TCU, who just happened to have a graduate assistantship available, who just happened to need to fill it, in the next 2 weeks. And so my experience ended with me driving in the middle of the night down to Texas from Ohio, going to class, and then finding a place to live. Like that's how last minute this was. I had nowhere to be. And then, you know how the story ends, right? 12 years later, married, children. It was like the best thing ever. It was really great. So following your intuition, it's really cool. It's so cool. I do want to pull back a little bit though, because when you're talking about treating people, you have the benefit and maybe the burden of personal experience with this as well, right? So it's like every case is not your case, but you have insider information. So I'm thinking back to you as a child with some of these compulsions and this developing. You obviously didn't have the vocabulary to just right out of the box say, I'm developing some OCD or I'm developing, So what was that experience like? What did you notice as being different for you? And how did your family and people that are close to you start reacting to that? I mean, did they support you? Were they concerned? Like, what was that like?
And up until I went to college, I didn't know anything about it, right? Like I didn't know anything about it. I'm sure if anything that I did know about obsessive compulsive disorder, it was probably what most people know, which is a lot of hand washing and a lot of like just right stuff, right? Having to have things be perfect or fear of germs. And those manifestations, 100%, they do happen. They can be extremely debilitating. I've worked with people who drank bleach because they like didn't want to have their insides contaminated, right? Like I get it. I get how debilitating this can be. I've worked with people who can't get out of a burning building during a fire because they like have to have things just right before they leave. So like, I definitely get it, but it's just a drop in the bucket as far as how OCD can come out. But we don't talk about that, right? It's easier to talk about the fearfulness of germs or like needing to have everything clean. It's just a little bit easier to talk about. It's not as taboo. And I mean, in hindsight, I think a lot of my anxiety came out in very like social ways, right? Oh my gosh, like who am I going to sit with at lunch? So I feel like I was probably viewed as like weird. And, I think my mom and my dad, they probably, they were dealing with their own stuff, right? And as we know, so much of this is passed down, right? So knowing what I know now, I look back at my parents' behaviors and I'm like, they probably definitely had some stuff going on. Like I remember my mom was always like extremely uncomfortable anytime that like one of my nieces or nephews would run around naked and she would like run out of the room. And I never thought anything of it. I just thought it was weird. But now that I look back, I'm like, oh my gosh, I wonder if she had like sexual intrusive thoughts. Like, I wonder if she had some stuff because there is a genetic component, right? There is a genetic component. It doesn't mean that if you have OCD that you're like 100% doomed, but obviously your learning environment too. And I wouldn't say that my parents were super bold, right? They weren't like, yes, let's do the hard things, right? Like they were kind of isolative themselves and probably anxious in a lot of ways. So I honestly don't think anybody thought anything of it. I just certainly thought like, this is the way that life is, like, this is the way that my brain works. And I'm always going to be anxious. And it's just like a day-to-day kind of thing. And this is just how I am, right? Like, I think we all walk around until we have a word for it or a name for it. We walk around and just think that there's something wrong with us.
Right. Or we walk around with the words we're given, right? Like you said, the word weird, like you could have been like the weird kid or quirky, right? If people were being kind, like she's just quirky. She has these things about her that are a little quirky, right? And they're actually symptomology that, in a trained professional would have looked at with a much different lens. And so I'm interested kind of right there. We don't have to get into like heavy diagnostics, but I wonder, what are some of those early signs that may be misattributed to quirkiness or, awkward or weird or whatever that are actually like, hey, there's more to look at here. This is something people should pay attention to.
I think it can come out in so many different ways. I mean, sometimes it can be, lots of anxious speech, right? Like constantly reassurance seeking, right? Like I have definitely worked with kids and adolescents and even adults who are like hyper verbal, where they're constantly talking or they're constantly confessing things and asking a bunch of questions. Whereas I can imagine the opposite, right? Like where you don't want to say anything because, like maybe you feel like it has to be just right before you say it, or, so on and so forth. So it really can come out in so many different ways. The red flags for me are when things have to be done, very rigidly, right? Like that it has to be done a certain way, and that things are done out of fear and anxiety, and urgency and desperation are always like my two red flags, right? Like where you are having to urgently and desperately do these things, that you're not necessarily doing them just because you prefer to do it, that like that's just the way they are, but it's like it's more of like a sense of urgency and desperation, right? And in that sense, like if they're not able to do things a certain way, like are they able to be flexible? Are they able to be okay with that change of pace, right? So like if someone, I don't know, I'm just thinking as far as academic stuff goes, if somebody maybe is really perfectionistic about how they're doing tests, right? Or like how they're rating something, how are they, spending a lot of time, maybe like filling in the bubbles perfectly? Are they like spending a lot of time on like one single sentence? That it's kind of like out of proportion to the actual threat, right? Like they're so perfectionistic about this teeny tiny one little piece of it that they're forgetting the big picture. And a lot with kids and adolescents, it's hard too, because sometimes we don't really see it as a problem, right? Like I work with a lot of kids and adolescents who, I don't know, they'll be like really shower ritual, for instance. They'll have to shower just right. If they miss a step, they'll have to go back and do it all over again, and then they'll miss school. And they're like, well, what's so bad about missing school? Like, I didn't really want to go anyway. And so they just are stuck in the cycle of having to, do their shower a certain way. And then who cares, right? Like they kind of get to miss school. The parents care, I think, in a lot of ways more than the kids. But yeah, it can come out in so many ways. There are like little more commonly seen subtypes. Like we have the contamination OCD and harm OCD, sexual intrusive thoughts. There's lots of different ways, but that's like by no means all of it, right? OCD can latch onto anything. So as far as red flags go, I always look for things like urgency and desperation. Like when things are needing to be done urgently and out of desperation, that's usually a sign that there's something else going on.
And I'm thinking about, we work with a lot of children in our practice as well. And I'm thinking about several children in particular that I wonder if this is a factor when you talk about that desperation, where if they're denied the ability to exercise the ritual or do things a certain way, you see the classic kid like melting down as they're being like drugged from the room. Like, no, we have to go now. And it's like, no, the stuffed animals are not in the correct order, or, my bed doesn't look a certain way. And like I've even seen instances where kids will like kind of burst back into the room and try to do the thing really fast, and it's like this weird kind of like inverse hostage situation. Like, no, we're going to take you out of here no matter what. And that certainly has those elements of urgency and desperation that like, what's going on? Why is this such an urgent need?
Yeah. And like, I don't know that too many kids or adolescents can articulate it. I don't know that we often ask them, or even if we did ask them, I don't know if they could articulate it, but that somehow there's some fear there, right? Like there's some fear there that like, if I don't have that just right, or like, if I leave here without having it that way, what are they afraid of? Right? Like there's some fear, right? There's some fear that's driving that. And it doesn't always have to make sense, right? Like it might be like, oh my gosh, if they're not all lined up, then one of the teddy bears is going to be sad. And like, I don't want my teddy bear to be sad that like that one teddy bear is on the floor and the rest of them are on the bed, right? It could also be like, I'm just going to be uncomfortable forever. And until I have that just right, like Rubik's Cube click feeling, I'm going to be uncomfortable forever. And of course, like that's something that we work on in treatment, right? Like, let's try, like, let's see if that uncomfortable feeling does last forever. Let's just go ahead and see what happens. And it doesn't, right? It absolutely doesn't.
At first, I can imagine like nervously eyeing the situation, you know what I mean? Like doing all they can to not like get out of the chair. And then over time it changes, Before we go on, I want to say a few words about Anew behavioral health. Anew Behavioral Health is an outpatient provider of mental health and substance abuse services in Ohio and New Hampshire. That means that Anew can successfully treat mental health and substance abuse issues or dual diagnosis if you're struggling with both. Their integrated approach allows for them to successfully address issues related to anxiety, depression, addiction, trauma, and really anything that stands between your life and the life you could be living. You really cannot bring them an issue that they have not successfully treated. They have also solved one of the biggest problems for people seeking help. They have a dedicated team waiting to hear from you at helpnow@anewbh.com. If you contact them today, within 24 hours, you will have heard back from, wait for this, a real live person, and will also have your first appointment scheduled at that time. So how do you contact them? Well, if you're in Ohio or New Hampshire, you're probably close to one of their local locations. You're welcome to go in. If not, you can always reach them online at anewbh.com. And if you're interested in services for you or loved one, use that address, helpnow@anewbh.com. So in extreme cases with this, right? So, you're letting us know, and I really do, like, this is not just being nice to the guest. I really do appreciate all the education around this, because we talk about depression so much and we talk about anxiety so much, and obviously there's big issues there. I think in day-to-day practice, we don't really talk about OCD so much, right? And I just worry that maybe what we've classified as anxiety could be connected to OCD, could be part of that root cause, could be part of that trauma experience. So I really do appreciate the education, but that's where I do want to go with it, though, is this issue of trauma, because that's another thing is kind of a catch-all word, is trauma. Do you see the OCD connected to trauma? Do you see the OCD as being a source of trauma because it's causing so much discomfort? Is it multidirectional? Like, what are you seeing in the population?
Yeah, it's super complicated, right? So first things first, when we're talking about PTSD, right? So post-traumatic stress disorder, at least insofar as the DSM, the Diagnostic and Statistical Manual, which I'm not a super fan of. I don't think any therapist is, but that's just what it is.
Well, it's made up. So, I mean, we can start there, right? It's made up by people who got in a room and got a collection of symptoms and said, they reached in their bag and they pulled out 3 words, right? Traumatic. I mean,
and then they don't talk to each other either, right? Like, the people who make this, they operate in silos and they never really talk to each other. Like, it's just, I could go on forever about that too. But so when we're talking about post-traumatic stress disorder, or PTSD, is different from trauma. So PTSD is when your life, or you have witnessed a life being actually threatened, right? So when we're talking about PTSD, we're talking about, things like sexual assault, like a near-death experience, something like that. That's not to say that trauma can happen in so many different ways too, right? Like, so not PTSD is traumatic, but not all trauma is necessarily PTSD, but it doesn't mean that it doesn't affect people, right? Like, there's no kind of like totem pole here. So trauma could be things like stressful life events, a divorce, someone cheating on you, prolonged like emotional abuse or neglect from your family, right? So the reality is that, yes, when we're talking about OCD and PTSD, it's far more common for those two things to actually happen together than for them to not happen together.
Oh, interesting.
So OCD and PTSD are much more likely to exist like in a comorbid sense than to not. So just that, there's that. And trauma is, trauma, again, now we're talking like kind of little t trauma, is more the exception than the rule. Or more the rule rather than the exception. So what that means is that generally people who have OCD, not always, but generally they have gone through some stressful life events, more so above and beyond than individuals kind of like outside of that clinical diagnosis of OCD. And we know that, like I mentioned earlier, as far as like the genetic predisposition, right? We know that there is a genetic predisposition for OCD. There's nothing that causes OCD. There's no one cause. So it's not like, oh, my trauma caused my OCD. It's like, no, it was a loaded gun, right? Like, you probably had a genetic predisposition. You had this like biological vulnerability to it. And this traumatic life event kind of pulled the trigger. So that definitely can happen. So stressful life events like that, traumatic life events like that can absolutely contribute to kind of the onset and the exacerbation of OCD symptoms. And they can make things really complicated, right? Because it's like, well, what am I avoiding because of my OCD? What am I avoiding because of my trauma? It can all get like really, really complicated. It can complicate treatment at times. And we know that the treatment for trauma, there are some like evidence-based treatments for trauma. We know EMDR is an evidence-based treatment for trauma. So is CPT, which is cognitive processing treatment, but also prolonged exposure therapy. So prolonged exposure therapy is not too far off of exposure and response prevention, which we would use for OCD and anxiety. So even if someone does come to me for OCD and they do have some trauma, I think it's important to highlight some of that stuff, right? I think it's important for people to understand like the ways that all these things can kind of come up and influence each other, just so that person can have a little bit of closure. But at the end of the day, I feel really, really strongly about identifying what are the ways that safety behaviors and avoidance, whether it's from OCD or from trauma, what are the ways that avoidance and rituals are getting in the way of you being able to live your life, right? Like if you, I don't know, like if you were cheated on, right? And that was like a stressful life event and that was very, very difficult for you. And we could say that that was traumatic for you. And you also have, OCD as far as contamination goes and whatever else, right? Like regardless, if you're avoiding going on dates, even though you really want to go on dates, I don't care whether that's necessarily because of the trauma or because of your OCD, right? Like my goal is to help you release and relinquish some of those problematic behaviors like avoidance and safety behaviors and stuff so that you can bust through that and live the life that you want to live, right? And to take risks. I always tell people like taking risks, and it's like the rite of passage to living a beautiful life. Like unless you are literally bubble wrapped in a corner and never doing anything with your life, like you're going to have to take some risks. And that doesn't necessarily mean that bad things will happen. It doesn't necessarily mean that your worst fears 100% will come true. It just means that it's a little bit risky. And I think sometimes, especially when you have OCD and trauma, you can obviously become very risk averse. And it's like, okay, that served you in so many ways, but now it's gone the complete opposite direction and you're not able to live the life that you want to live. So how do we get you to be able to live the life that you want to live?
I love that phrase that taking risk is a prerequisite to a beautiful life. It's so true, right? Because without the struggle, right? Where's that feeling of achievement? Where's that feeling of, accomplishment? Really, it's hard to develop a sense of meaning around life factors that were just sort of handed to you, right? And I think we see this a lot of times in like the quote unquote affluenza, right? Where you have families of higher resources and there's all these stories about how the kids can get way off track. And it's sort of like, well, yeah, because how do you find purpose and meaning in something that just is? Where was your piece of that? Hearing you talk about the connection between PTSD, trauma, and OCD, is your personal perspective on this that what we call OCD is maybe even comforting or coping skills that have kind of taken over, or are they more, do you think of them more as coping skills or compulsions? Do you think of them more as, because like an addiction, they talk about addiction is actually a coping mechanism and a comforting mechanism that has gotten out of control. We see so much trauma in addiction. You begin to drink to deal with those feelings. Next thing you know, the drink is the problem, but it wasn't the problem that caused your problem, right? So do you view that? Do you feel like, I mean, in a way, is OCD symptomology actually good? Scary word we're not supposed to use, but is it good for the person? But now it's almost gotten out of control to where it's now become the problem. Is it, that's what I'm really driving at. Is it a compulsion in and of itself that has negative connotations, or is it just an out of control coping mechanism that we've got to learn how to harness? I don't know. What do you see in your work?
I have so many things. So remind me, I'm going to talk about how this stuff all exists on a spectrum. And I want to talk about, oh my gosh, I don't want to lose it. I'll talk about the spectrum piece first. Oh, and how no behavior is inherently good nor bad. So I'll start there first before I lose it.
I knew you were going to chomp onto that. That's why I did the good thing. I knew you were going to love that so much. Okay.
And I don't want to forget.
We'll remember that one. So do the spectrum first, because we'll remember the good. Yeah.
So I always say, like, regardless of whether it's like addiction or, anxiety, PTSD, OCD, like no behavior is inherently good or bad. It's all about the function, right? Like it's all about, I always ask and laugh with my clients, like WTF? What is the function? So what's the function of you washing your hands, right? What is the function of you seeking reassurance? What is the function of you going to Google? What is the function of you not walking down that dark alleyway, right? And, like really to think about it, like, is that driven by fear and anxiety, or is that like just something that you want to do, right? Like, and you have to be honest with yourself, right? Sometimes we can say like, oh yeah, I just want to I'm fine. Like, I don't have a problem with washing my hands, but obviously you do, right? So, just things to think about, but no behavior is inherently good or bad. It's all about the function, right? And so if you're doing something repetitively and urgently and out of desperation, and you're doing it out of fear, it kind of fits all the criteria of a compulsion, right? So it is in that way, it is temporarily relieving that sense of discomfort that you feel from the anxiety or from the obsession, but it just gives it credibility for next time, right? So, if somebody washes their hands after feeling dirty, it's like, okay, they get that temporary feeling of relief, but then you've just given credibility to that feeling that you can't handle being dirty and that you needed to wash your hands in the first place, right? That's kind of how the cycle works. So there's that. But then the other piece was how all of these exist on a spectrum, right? Like, even like when it comes to alcohol use, right? Like it all exists on a spectrum. Even things like psychotic symptoms. I'm sure we've all had that experience where like we feel our phone vibrating in our pocket, but our phone isn't in our pocket, right? Like that's a little, like that is a very, very, very mild kind of hallucination, right? And we all experience these things to some degree when it comes to anxiety, when it comes to depression, right? Like we have low mood, we have lack of appetite or just loss of pleasure and stuff. It doesn't necessarily mean that we meet criteria for it, but we all experience these things on a spectrum. And it's the same for obsessive compulsive disorder. So we all have obsessions. Obsessions are intrusive thoughts, ideas, images, impulses, or feelings. And we've done research to show that regardless of where you are in the world, regardless of your socioeconomic status, your mental health background, everyone has these like weird, intrusive, unwanted, unwelcome thoughts that come in, right? Like about oh my gosh, I just imagined grandma having sex, or, oh my gosh, like I just like randomly thought what would happen if I just swerved my car off this bridge or whatever, right? Like we all have had those thoughts before. So no, we're never going to get rid of those, right? And that's not necessarily indicative that you have OCD. So that's the O piece, the obsession piece. We all also do compulsions, right? Like, I don't care whether it's avoidance. I don't care whether it's like asking for reassurance, right? Like we all do things from day to day that are out of anxiety that probably aren't that great for us in the long run, but we do it anyway, right? So we all have the O, we all have some of the C, but when it becomes disordered, that's where it's like, okay, this is something else. Like, this is no longer good for you. This is no longer okay. Like, this is to another threshold. So the disorder piece, it's where we look at distress and impairment. So distress is, this is really affecting you in your life. It's causing a lot of stress, maybe to you and your family. It's, you do not like the way that you're living. This is where we really feel strongly as a community. Like, if you like it, it's not OCD, right? Like if you like living your life this way, this is not OCD. It's causing a lot of distress. And then also impairment. So the extent to which these behaviors or obsessions or distress is causing you to no longer be able to fulfill your activities of daily living. So, not being able to eat, not being able to drink or take care of yourself, be on time for work, all that stuff. And then there is one loose, in the DSM, I don't really use it. It's hard to kind of quantify some of this stuff, but technically these things generally, in order to be OCD with the disorder, it should take up more than an hour a day. But again, like, how do you quantify avoidance, right? Like if somebody is avoiding doing their laundry, or if somebody is avoiding, pictures of magazines with little kids in them, right? Like how does that's not really like a quantifiable amount of time. So we all have a little bit of it. And, and that's great. That's fine. Like, there's nothing wrong with saying that. To say that we all have like symptoms of it is probably more legitimate. The same way that we all have from day to day, we all have and exhibit symptoms of depression, right? But it doesn't mean that you have major depressive disorder.
I think that's interesting. I am really glad you use those examples though, because before the show, Ian was talking about how he was thinking about his grandma having sex, but in a car. So you combine both of them, right? No, I'm kidding.
I think it kind of strange.
So I don't know if it ruined driving for him or what, but Ian, this is good to hear that we're all dealing with this. So this is no problem.
Yeah. And regular everyday people, for the most part, they have those thoughts and they're like, oh my God, that was so weird. I don't know what the hell that was. And they kind of let it go, right? They don't hook into it. They don't connect to it. But where people with OCD go haywire, their brains are, I always call it like, it's a little bit more like Velcro. They can't just allow that thought to come and go because, and here's the kicker, they misinterpret that thought as being significant somehow. So like, oh my gosh, what does that mean about me that I just had that thought about my grandma? Like, am I actually attracted to her? Like, why did I have that thought? That is such a nasty thought. That is so inappropriate. That is so bad. I never want to have that thought again. And it's like, all the while you're telling yourself that and getting emotionally invested in that thought, your brain, unconsciously or not, you're giving your brain the message that this thought is really important and you are a sicko and we need to make sure that you never have that thought again. So now we can't go to grandma's house. Now we can't even think about grandma. Like, no one can talk about and like suddenly your world is just like effed.
Yeah, and it's the quickest way, too, to sit there and say, we can never have that thought again. It's like the old white elephant example. Like, I need you to not think about a white elephant. Boom, what's in your head, right? And so it becomes that same self-fulfilling deal. So this is kind of a weird question, and it'll be a spectrum answer as well, but because all of us have some of this, and because there's elements there, and because, and there are ways to, deal with this and cope with this. The Velcro example is amazing because everybody's had that like on top of a building jump thought, you know what I mean? But it just kind of goes. So how bad can this get, right? Because it sounds like we all live with elements of this. And so when we think about treatment, we think about people listening to this saying, well, I might have some of these elements, I might have some of this going on, but what's the big deal? Because we all have it. I mean, can this be fully debilitating? Can people lose their lives over this?
I mean, like, as you're even talking, I have like full body chills, right? Because I fully believe that OCD, and so many people out there who are probably listening, they're like, oh yeah, it was really bad for me, but it hasn't been for the past couple of weeks. So just to warn everybody, OCD naturally follows a waxing and waning course, which means that it is very episodic in its presentation. So you might go 3 months and it's really, really debilitating or like really awful, but then all of a sudden it's like, I don't know what my deal was for the past 3 months. And you might feel like, okay, that was just a thing. And then 3 months later, it happens again. But it's stronger, right? And so like that next wave is even stronger and more gripping. So just keep that in mind. Like, if you feel like you're resonating with this, but you're one of those people who are like, well, I've been fine for the past few weeks, like just keep this in mind, keep this conversation in mind, because it might be still a struggle for you in a little bit. I hope not. But I'm a really firm believer that, and I don't even think it has to be necessarily with a therapist, right? Like, obviously I would want everybody to have an OCD therapist and an anxiety specialist who like really understand these concepts, but that's not the case, right? Like, it's hard to find somebody, let alone somebody who really understands this treatment. I believe 100% that people will not get better from OCD and anxiety unless they're doing these 3 things, unless they are pushing themselves outside of their comfort zones, unless they are reducing their compulsions / rituals / safety behaviors. I use them all synonymously, and reducing avoidance. So those 3 things. I do not think that you can do whatever you want. You can take whatever medication you want. You can take whatever supplements you want. But if you are not doing those 3 things with or without a therapist, you will continue to struggle and your life will continue to get smaller and smaller and smaller. So there's that. But it can get so, if you don't do that, it can get so small. Your world can get so small. So like I said, I worked at a residential facility where, for those who don't know, it is the highest level of care that's not inpatient. So inpatient is reserved solely for people who are in active threat, like they are actively wanting to harm themselves or somebody else. So residential, on the other hand, they're not necessarily in that zone, but they're so debilitated that they cannot take care of themselves. It is essentially like a home for people who have OCD and anxiety. So they would, from all over the country, they would pack their bags and they would stay with us in a big mansion for 45 to 60 days. And some people stayed there for longer. Sometimes people stayed there for like 2 years. And they got 24/7 care, right? Like 24/7, there were nurses and 24/7 staff. Like I said, some of the cases that stand out, I worked with somebody who would drink bleach, right? Because she was just she didn't like the concept of like that she ate something contaminated. I've worked with people who would get in, one person got into 6 car accidents because they were so sleep deprived, like having to stay up and do their rituals, that her doctor basically said, like, if you don't go here, I'm admitting you, meaning like I'm sending your butt to a locked up facility, right? Like you are going to go to an institution. I've worked with people who would like Lysol their entire bodies, and they had like open wounds and like open sores all throughout their body. I worked with a mom who had a baby and didn't hold her baby for the first 6 months because she was terrified of like hurting him. She was terrified of hurting him. And all of these thoughts are ego dystonic, right? So ego dystonic is a fancy word that just means it's inconsistent with your values. So even when it comes to things like harm intrusive thoughts, like these unwelcome intrusive thoughts of harming someone, either on purpose or an accident, it's very unwelcome. It's very like, it's inconsistent with their values and who they think they are as a person. And so it really freaks them out. And they're like so anti wanting to do that they'll go 6 months having a newborn baby and not even touch them. So many other, I've worked with numerous people who have committed suicide because it's just like, there is just such an isolative way to live. And it's terrifying. I know even for me, so my issues really got bad when I had my son back in 2018. I struggled with a lot of harm intrusive thoughts and sexual intrusive thoughts with my son. But a big one was that I was terrified that I was like I was terrified that I was so sleep deprived that like, was I actually dreaming reality? And so me, like knowing everything that I knew about OCD, I was like pinching myself to where I had bruises. I was pinching myself because I wanted to just like know that I wasn't sleeping, because I was afraid that, like anytime that I brought my son anywhere, I would be like, okay, like you got him in his car seat. And then I would have that intrusive thought come in of like, well, are you sure? Or are you sleeping? Are you so sleep deprived that you think you put him in his car seat, but you actually left him at the park? And so it started off by me, like I would just check in my mirror to make sure that he was there. Eventually that wasn't enough. And then I had to like reach around and touch him and make sure that he was there. Eventually that wasn't enough. And by the end of my maternity leave, so 3 months, I was pulling aside of highways to like physically take my son out of his car seat, and like semi trucks whizzing by me at like 65 miles an hour. And I was taking him out of his car seat in the middle of the highway, like trying to reassure myself that I wasn't sleeping. And yeah, that was how bad it got in 3 months, right? Imagine if people do this for 35 years. Like, it's awful. It's awful. It is literally, I'm sure people have heard it before, like, but from the World Health Organization, it is one of the most debilitating conditions, but it's also one of the most treatable. So that's like where the controversy is, right? It's like, it is one of the most debilitating conditions, but it's also the most treatable. So like, how do we get this treatment to more people? How do we get more information to people? Because it's like, once we can get them the treatment, they're good, but we just need to get them the treatment.
Well, I'm curious, as you describe the progression of, your OCD, why does it get worse? Why isn't it a thing that just deal with it? It doesn't get worse or better, but it just gets worse.
So here's the cycle. So I'm visualizing it right here, right now in front of me. But so at the beginning of it, right, we have those very normal intrusive thoughts. doubts, uncertainties, so on and so forth, like those normal intrusive thoughts. And that's not even part of the problem, right? Because you have them, I have them, we all have them. That's not part of the problem. But where the cycle kicks off is where we start to, again, misinterpret those thoughts as being significant somehow. Oh my gosh, what does that mean about me that I had that thought about my grandma? What does that mean about me that I had that thought about swerving my car off the road? Does that mean I actually want to do that? Oh my gosh, I can't tolerate that thought. I don't want to have that thought again. And so as we start to, emotionally invest like that, right? Like, I don't want to think about that. Oh my gosh, what's that mean about me? We start to get very anxious, right? We start to get very anxious and worked up. Our fight or flight response is kicking in. And we don't like to feel anxious, right? We talked about this before airing. Like, we live in a society where like anxiety is bad and we need to fix anything that's uncomfortable. And so we don't want to just sit with that anxiety, right? Like, we interpret that as like a red light that we have to go and we have to do something about it. And so then we go and we do some type of compulsion or ritual or safety behavior. You could also call it an anxiety reducing behavior. I don't care what you call it, but you go and do something to try to out that initial obsession. So whether that's like shaking your head, oh my gosh, I don't want to think about grandma, whether it's like, I don't know, telling yourself like, oh yeah, that's fine. Like, that's just a normal intrusive thought. Like, I don't mean anything by that. You would never think that way of your grandma. Like, whatever it is that you're doing, maybe you Google, right? You come home and you Google and you're like, had a thought about my grandma. What does this mean? If you're doing something like that, right? It's probably going to temporarily make you feel better. Like, oh, okay. Yes, I would never do anything like that. Thank goodness. But here's why it gets stronger. Because even though that temporarily makes you feel better in that moment, no, is just consciously or not, you've just given credibility to that initial obsession. Like, oh, so it is bad to think about your grandma that way. Okay. Like, we'll make sure you never have that thought again. And so in order to make you never have that thought again, your brain is like, okay, we can't go to grandma's house. So when it's grandma's birthday next week and you're like, oh my God, I can't go to that. I can't have that thought. I can't have that thought. And so you avoid grandma's birthday because you don't want to have that thought. And it's like, okay, cool. I avoided grandma's birthday, so I don't have to feel anxious. And it's like, but what you've just done is you've just given that initial fear of grandma credibility. You've just given your brain the message that grandma is bad. Being around grandma is bad. These thoughts about grandma is bad. And that good thing you didn't go to grandma's birthday party. Otherwise you would have had that thought and you wouldn't have been able to tolerate it. And so then it's Christmas, right? And then it's like, okay, oh my God, like, no, you're even more afraid of grandma. And it's nasty. It's nasty, nasty, nasty.
And it grows, right? Because next, all the pictures of grandma have to come down, and then anything grandma gave you has to get thrown away.
And then grandma, you realize that mom starts to look like grandma a little bit. So now you can't even talk to your mom.
Right.
And then it's like, oh my gosh, am I a psychopath? What am I? How could I ever possibly be trusted with another woman? Right? Like, I can't date people. I'm just a crazy psychopath.
Right. The labels, once the labels come in, then you're going to live up or down to that expectation of those labels. You shared a little bit. I had this question sitting in my brain while you were talking, but you kind of got into it a little bit with the distress of your child and pulling over and things like that. But as a mother, living with this and dealing with this, what is that like on a day-to-day basis? Do you still deal with the waxing and waning of that? Has that passed? Or are there things that you do on a maintenance schedule or a preemptive schedule to make sure you don't go back to that place? I'm just wondering what life is like day in and day out with that.
Yeah. So I definitely went through the very rigorous and like very, concerted efforts of doing exposure and response prevention. So I eventually went to therapy myself. I got on medication, which saved my life. And yeah, like, I live the lifestyle, and I have since 2019 when I went to therapy. I live the lifestyle of ERP, right? Like, I don't necessarily do like, oh my gosh, okay, these are the exposures that I'm going to do today. And these are the exposures that I'm going to do today. And this is what I'm going to resist. It's like, no, it's just a way of being now. Like, it's just a way of being. And so I don't know, every once in a while, when my son sneaks into bed with me, sometimes I'll have this intrusive thought of like, well, you need to like face him while he's sleeping, right? Like, you can't have, like, you need to actually face him because he's going to die and you're going to be really regretful that like you didn't soak up that last moment. Like, I think a lot of work, like I could come back, we'd have to come back for another episode to talk about it, but there's a lot of like work that people can do about something called core fears. So a lot of times OCD boils down to a couple of core fears, like fear of regret, fear of being uncomfortable forever, fear of being ostracized from society, fear of being a bad person, right? And through my work, I have realized that a lot of my thoughts come from fear of regret, even back to the Hansen stuff. I feel like my fear would be that if I did harm one of those Hansen brothers, I would have to live with that regret forever. And that would be a horrific way to live. It's not all that different from the fear that I have when my son sneaks into bed with me and my intrusive thoughts tell me, you better, roll over and make sure that you're facing him, because if he dies tomorrow, you're going to regret not doing that. It's the same entity.
Are those core fears taught? Are they come part of the software? Like, did you come out of the factory with those fears inherent and they developed, or do you think they were learned?
I don't know. I think it's probably a little bit of both, right? Like if I were to even go back and consider in my own childhood, like fear of regret, like I probably was modeled that in lots of different ways. And so, I mean, it's a good question. I don't know to what extent there is like, if there is like a genetic predisposition for that too. Like I would be so fascinated by that. I wouldn't be surprised by that if there was. But again, like there's so much learning, right? Like think about the messages that we're given throughout life. Like those like motherhood thing, like, oh, just make sure you enjoy every single moment. My mom was one of those moms, like, don't be on your phone when you're holding him. Like you want to be with him. You want to remember this. And I'm like, okay, well, I guess I like have to remember every single little thing. Right. So yeah, I would venture to say that they're probably more learned, either like consciously or unconsciously, but there's probably some genetic predisposition too. But yeah, it comes up. But I hope it makes sense that it's the same entity, right? Like the same entity that haunted me as a kid with Hansen. It's the same entity that tries to stop me when my son sneaks into my bed, right? Like it's fear of regret. It's just, it comes up in different ways. And so I think like to truly master recovery, you have to really know your opponent is how I always describe it. Like you really have to know your opponent. And you kind of have to be, it's like chess. You kind of have to be one step ahead of the game. And so I can see in advance where my mind might go, right? Like I have to go away for work to a huge conference in California in July. I've never been alone away from my son for more than 24 hours. And I'm going to be away from him for like a week. And I already know going into that, like that I'm going to have a ton of intrusive thoughts and a ton of doubt about like, Eli's going to die. And like, you're going to kick yourself in the butt because you went away on this stupid work trip. And I just have all these imagined scenarios about me being like dying on my deathbed in a hospital bed, like just crying and mourning about my loss of time. And like, I'm going to have to roll with that. Like, I'm still going to have to go on the trip. My OCD would want me to be with him 100% of the time. But like, it's also my values to like go and take care of the work that I have to take care of, right? Like he's not the only part of my life. So working with values is really important, right? Like making sure that you're making intentional decisions based on your values versus making decisions out of what fear wants you to do. So I'm very much recovered. I don't think I would meet even diagnostic criteria for it anymore, but it's a lot of work. And it's like tenaciously and ruthlessly just protecting that and making sure that I do the opposite of what OCD wants me to do, that I'm being guided by my values and not my fears, and a lot of other things.
Can you imagine having the same conversation, probably not by video, but like in the medieval ages, and you're coming to me in the town square and you're saying, no, but in all seriousness, and you're saying, I have an entity and it's inside me and it's telling me things that nobody would ever, there's no wonder that we walked around thinking we were possessed all the time, right? This was undiagnosed OCD without a doubt. It had to have been.
It was around, but it would have to be in different ways, right? Because I think there's also like a hierarchy of needs, right? Like,
sure.
Like it's, there's so much more about that, right? Like access to care and money and like cultural kind of like levels of acceptance around mental health. But like people in lower socioeconomic statuses, like they don't have OCD as much. Again, like there's so much about, I'm sure they do, but they're also, it's hard to be worried about these like higher level things when like you're legitimately worried about like what you're going to eat next. You know what I'm saying?
When there's food on the table, there's lots to talk about, right? When there's no food on the table, there's one thing to talk about. You know, it's like
100%.
you and your entity, get your butt out in that field, pick the berries because we got to eat tonight. You know, that's the end of that.
Like, who cares, right? Like, I don't have, I do, there's a little, I don't want to say the word privilege, but kind of, right? Like, I'm so lucky that I have the mental space to even care about some of this stuff because like I do have a house and I do have income and like, so there's a lot that I would love for people to research because I think there's like, I keep coming back to like the hierarchy of needs.
50 Cent just said that you're aligned with one of the great philosophers of our time. He said depression is a luxury, you know, because he said in my neighborhood.
I kind of believe that. I'm probably gonna get canceled for that.
I'll be right there with you. I set you up for it, so we'll go down together. That's fine.
I kind of believe it, right? Like I don't know, like totally. There's so many different levels of like why people in lower socioeconomic statuses wouldn't be diagnosed with OCD. Like obviously they're not as able to come and talk about it. They don't have access to care, right? Like insurance. So I get that. And they're probably worried about other things, right?
Well, and if you come back to that socioeconomic situation, whether it be cultural or whatever, and you say, you know, my doctors feel like I have OCD. Do you get labeled crazy? Are you now ostracized from all of your friends and family? So that acceptance is a big piece of it too, right? That's like saying, you know, cats of poor families don't get kidney disease very often, or cats from poor families don't get taken to the vet, right? I mean, it could be a couple of different factors there.
There's so many levels, but I think the point and like that we're trying to make, right, is that like, yeah, I just keep coming back to the old school, like Maslow's hierarchy of needs. Just that's in my mind right now.
No, and it's amazing. And we actually should do a follow-up if you're game. We should talk about this. Like I would love to talk to you right after your trip. I would love, because you're already anticipating it. I mean, I'm not even kidding about this. Like we'll book it. I would love that. And really you should, I don't know what you're doing with your socials, but you should make time each day to live stream, and you really should go through that and share that because you've helped me so much understanding this already. I'm thinking about other clients and like, I didn't know any of this. And
yeah,
the authenticity of your experience is just striking.
Oh, thanks. It's hard to cram it in an hour, but hopefully it's enough. And yeah, I'm happy to come back anytime.
Well, and I don't want to get rid of you just yet. Before we do go, I want to talk about this. You've talked about this treatment modality, right? So it's the ERP. Is that what you kind of is like the gold standard? Again, its own episode by itself. I'm sure you could write a dissertation on it, but you seem to be very excited about it. It seems to be something that has a lot of success, something that's helped you personally. So can you give us sort of the foundations and what we can expect from that? Because it's very hopeful, I think, for people to know that there is help out there and there's proven treatments. So yeah, what goes into that?
So ERP is one of the most well-studied and well-documented and empirically supported behavioral interventions that exist, if not the most, right? So when we say that, essentially what that means in a not so nerdy sense is that we've done tons of research, tons of controlled and randomized trials with people about this, and it works. It works. And obviously nothing is perfect. People are complicated and nothing is perfect. Like there's no cure, like nothing is a 100% go, but ERP has been shown to be more effective for OCD and anxiety than any other treatment for any other condition. And so again, it's like that very frustrating, but very like hopeful juxtaposition of like how debilitating OCD is, but it also has this treatment that is the most effective treatment. So it's really just a matter of educating people about it and getting it out there. So exposure and response prevention, it's been around for a very long time. But essentially it is a two-part solution to a two-part problem. So exposure and then response prevention, and the two-part problem being obsessions and compulsions. So exposure really refers to this intentional and purposeful act of going outside of your comfort zone. So you are doing exposures, you're doing anxiety-provoking things. You are putting yourself in anxiety-provoking situations, but it's important to do it in a way that's challenging but manageable. So it is not just like, okay, like I'm going to go and jump off the deep end then, or like, I'm going to go and like spend a week away from my kid. Like, no, it's supposed to be very challenging, very manageable. It's supposed to be very collaborative, and maybe you're out like an hour away from your kid. Like you go to the gym, right? Versus a whole week away. But what's really important is you can't just do the exposure. You can't just do the anxiety provoking thing, because if you just do the compulsion or the safety behavior that you're used to doing to feel better about that, then you're just going to end up back at square one and kind of negating your work. So just for really like practical examples here, if somebody had contamination OCD and they were really fearful of getting sick and germs and touching stuff, they can't just shake someone's hand and then go wash their hands after, right? Like you'd have to shake someone's hand and then sit with that. Like you'd have to continue to live your life. Because if you just shake someone's hand and then go wash your hands afterwards, you're not really doing anything different than what you normally did, right? And so at best, you're just negating your progress. And at worst, you're actually making the OCD worse because it has one more experience and one more association, right? So really, really important. People kind of think that the exposure aspect to it is like the sexy part, like, ooh, exposures. It's like ritual prevention or response prevention, resisting your compulsions. That's actually the most important piece of it. So you really need to make sure that you are resisting your compulsions, working with somebody to help identify what your compulsions are. So what are the things that you're doing to try to make yourself feel better about your obsession? There's lots of good examples online and lots that you can learn about as far as what your compulsions might be. But yeah, I mean, you really work with a therapist ideally, but you could, practice on your own too. You do exposures in a way that's challenging but manageable, and you work to come out of OCD's pattern by messing up the rituals that you normally would do. You ideally would resist those rituals, but you can also play around with like reducing compulsions or postponing compulsions. So, maybe I shake someone's hand and then I'm going to let my hands be dirty for 20 minutes before I go and wash my hands, right? Instead of going and doing it right away. Or maybe I'm just going to wipe my hands off on my pants instead of going and washing them under scalding hot water with 5 pumps of soap. There's lots of cool things to do. It is amazing. People generally feel better, like just even from like the first session, right? Like you can imagine just like having an in-depth kind of psychoeducation session about this. People start to feel better. But, it's very active. We do exposures together in session. It's amazing. It's absolutely amazing.
So this is how we treat allergies in the body, right? So you get a histamine response to some type of invasive anything, substance, whatever, pollen, right? And so now your body swells up. You get all this congestion.
It's like, what the heck have you just done?
Right, so that's the RP, right, of the ERP here. That's the response, and so you inject a little bit of the pollen, right, in a controlled way. This is the exposure. The body flares up. You do it again, flares up a little less, flares up a little less, flares up a little less. Next thing you know, you're in a field of flowers, breathing just fine, right?
Absolutely.
This is just that in a behavioral context with a little bit of systematic desensitization thrown in for fun, right? Like, yeah, okay, that's amazing.
And it works via habituation. So habituation is just this fancy word of saying that you eventually get used to it, right? So you get used to it, you get used to it, you get used to it. When you're not like constantly escaping the anxiety state, you eventually learn that anxiety can't last forever. And your parasympathetic nervous system eventually kicks into gear without you having to do anything about it. But also there is this inhibitory learning model, which just says that you essentially learn through new corrective experiences, you learn that your worst fear wasn't as likely to happen. It's not as catastrophic as you think that it is. And then here's my favorite part is even if your fear does come true, you learn to handle it. I work with so many people who are like absolutely terrified of getting sick or terrified of, whatever, being judged or getting in an argument or insert whatever fear here. And it's like, sometimes that happens, right? Like sometimes you do get judged or sometimes you do get criticism at work or sometimes you do get sick, right? That happens. And it's like, okay. And the world continues to spin and you can handle it. You can sit with that. And it doesn't have to be this like world ending thing.
Can you imagine those poor OCD contamination folks during COVID with the masks and the spray? And I mean, you don't have to imagine, you lived it, but.
Imagine So I still worked at residential during that. I imagine I swear I'll write a book about it one day. Like there's nothing more wild than working in an OCD and anxiety residential facility during COVID.
I can't even imagine it. I can't even.
Because what we're doing, we didn't allow people to have hand sanitizer. We didn't allow people to have any cleaning products. We barely allowed people soap to wash their hands.
Right.
So now all of a sudden, we're giving people hand sanitizer and making them, even if they don't want to, we're making them Lysol stuff that they've touched. And it's oh my gosh,
Yep. And I wonder how many new cases out in the world we unlocked. Because you think about reinforcement, it's a credible threat.
Totally. I know so many people, in fact, that they did great. They did awesome, and they really, really stood by it. And then they were thrown back into this pandemic, because of the pandemic, they were thrown back into, they were forced into having to, wash their hands when they wouldn't have normally been doing so. And they really have struggled more.
There's about 6 things we got into that are their own show. I think that would be its own show.
I'll be a recurring guest.
We might need to get you in a featured spot, something like that on a repeating role. So I want to be respectful of your time. So we'll cut short here, but we will absolutely get together again. I'm serious about following your conference and hearing how that goes. I think that's a good place to start. We still have our office episode out there.
People love the real life stuff.
Yeah. They want to see the reality of it. Books are boring and nobody reads anymore anyway, right? So nobody wants to read a paper about it. They want to see the real life thing. And like I was saying, we have our office episode coming because Jenna and I are battling over who the biggest Office fan is on this podcast. And so we've got I think that's the perfect response prevention thing to calm down is don't wash your hands, don't do anything. Just go watch an episode of The Office. You'll chill out, you'll relax, you'll laugh a little bit, and you'll be fine. So, Jenna, how can everybody find you? How can we catch up on your content and what you're doing? How can we track this? Where are you at?
Instagram. So I'm at Jenna.Overbaugh, just my first and last name with a period, over on Instagram and on TikTok. But I have a website too. So I have lots of resources on my website. I have courses, workshops, lots of cool little community things that I'm trying to do. So that's at www.jennaoverbaughLPC.com. And then I have a podcast as well. It's called All the Hard Things. So if you want to do a deeper dive and learn more about OCD and anxiety and exposure and response prevention, lots and lots of episodes. I think over 150 now, or getting close to 100 and something. But yeah, lots of resources out there. Also, if anybody wants to learn more just in general about OCD, I always recommend the International OCD Foundation. That's iocdf.org. They're a really reputable source of information. Unfortunately, a lot of the stuff that you read out there about OCD is not necessarily totally legit. So iocdf.org is really a good place to start.
Amazing. And of course, we'll post all that in our show notes and make sure that everybody has links to your stuff below. So I'm always supposed to point, it's all down here. I don't know where down here is, but it's going to be down here. So thank you so much. That is our time. I wish it wasn't. I wish we were half done, but we will definitely have to do this again, Jenna. So I appreciate you so much.
I appreciate you. Thank you.
And everybody watching at home or listening, whatever you're doing, or if you're in your car, hopefully keeping it on the right side of the road, not giving into those intrusive thoughts, listening to us. I want to thank you guys for your time as well. Always giving a shout out to Anew Behavioral Health. You guys heard the commercial spot halfway through this, but I can always reach those folks at anewbh.com. Psychiatrists, therapists, nurses, case managers, all the behavioral health specialists to help treat things like OCD, to help manage these conditions. Jenna made the comment that, some of the behavioral interventions and the medications that she uses saved her life. And the exact same thing is possible for you with good help and proper diagnosis. So if you're in Ohio, New Hampshire, I hope you reach out to those folks, anewbh.com. Again, thanks to Jenna. Thanks to Ian for being here and producing. Thanks to all of you for listening. And until next time, take care of yourself. Take care of each other. Appreciate you. Hey guys, although Through Help and Back is an excellent podcast with a lot of great ideas, I do want to let you know that in no way is Through Help and Back expected to be perceived as or relied upon in any way as specific medical advice or mental health advice for you personally. The information provided through Help and Back on our website or our podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment that can be provided by your own providers. Do not use our content in lieu of professional advice given by qualified medical professionals, and do not disregard professional medical advice or delay seeking professional advice because of the information you have read on our website, heard on our podcast, or otherwise received from us. Although we love discussing issues related to healthcare, mental health, and addiction, we are not providing direct healthcare, mental health care, medical, or nutrition therapy services. We're not attempting to diagnose, treat, prevent, or cure in any manner whatsoever any physical or psychological ailment, any mental or emotional issue, disease, or condition. We are not giving you specific medical, psychological, or religious advice whatsoever. Please take care of yourself and take care of others as you always seek the advice of your own medical providers and your own mental health providers regarding any questions or concerns you have about your specific health, or before implementing any recommendations or suggestions from us. These are ideas that have worked for other people. We think it's important to share them. We do not guarantee that they will work for you specifically. Do not stop taking any medications without speaking to your physician, nurse practitioner, physician assistant, mental health provider, or any other healthcare or medical professional. And if you have or suspect that you have a medical or mental health issue, contact your own healthcare provider promptly. Also, one last thing, if you know or suspect that you are currently experiencing a crisis, it is absolutely imperative that you seek the advice of your doctor or other emergency healthcare services prior to ever thinking about using our content. We love the conversations. We're glad you're stopping by. We hope you take a lot from the content. But again, for your specific individual medical situation, please always seek quality personal care from your own providers. Do not let this information or this advice stand on its own. Thanks so much for listening.